Assalamu alaikum. Thank you very much, Punjab, Pakistan Pediatric Association for inviting me, and thank you, Dr. Masood Sadiq, for the primer. I think that makes my job easier. The participants at least are primed, inshallah. So, I was supposed to talk about preventing medical errors, and this is for the lack of a better topic because Dr. Naeem Zafar said, you take your pick because this is the theme around which we are talking, so if you want any change. So I just said beyond human flaws, and then I was just thinking a little while back, I had selected the wrong word. It was beyond human folly. So a little twist to that. But we'll start with this fancy figures which come from the people we love to hate, the armchair statisticians from the donor agencies who move around in those donor-funded large SUVs, and most of us clinicians actually think they don't really get their hands dirty, apply complex statistics, and reach those numbers that may not be true. But and I agree to some extent. Here are the numbers, and I'll just focus on South Africa that I have, South Asia that I've highlighted. And what you see is that we often talk about access to healthcare. Here we're talking about patients who had access to healthcare, went to healthcare facility, got treated by healthcare workers, and were harmed because, as a consequence. And this number is highest in case of South Asia, this region. And when I said they give, and these are the conditions in which patients who are receiving that care, so there's those two categories of lack of kind of marginalization of the population. One is people do not have the access to, and the healthcare is not utilized, and the other is poor quality as the result of which the patients are harmed, and cardiovascular diseases are right there at the top. Interestingly, in this figure, which comes from was published in Lancet in 2018, they did not mention the burden of surgery, and if you include the burden of surgery, then this becomes really a massive problem. However, and the reason I said I agree, I think this is a gross underestimate, because if we stop measuring the outcome of harm in terms of patients dying and look at the other harms that we are caused as a consequence of treatment, then this number is a lot larger than that. We see that happening every day. The patients being harmed because of overtreatment. I mean, let's look at it this way. A person has selected to go for what we call as allopathic medicine as the treatment modality. They go to the community, and what I find, I come from a rural background and I have connections there, and you do talk to people who are in the marginalized areas here, and if you talk to them and you ask them, what you'll find is the number of the amount of resources they are spending on healthcare every month makes a substantial proportion of their monthly earnings. Every other day, one of them is unwell, and when they get unwell, they go to a GP, a community doctor, who gives them a drip with some injections, charges them something like 500 to 1,000 rupees, and that cycle continues. And most of the times they are getting a steroid and an antibiotic, so rampant use of antibiotics, steroids. I'll refer to a study published by Khan and I was a group of doctors working in Khan Community Medicine, Public Health Department, and I was fortunate to be a part of that discussion when I was with Pakistan Medical Commission as people who had collaborated in that study, and I have continued that collaboration, and they are looking at the prescribing pattern for antibiotics amongst the general practitioners, and it is not exactly revealing on the incentives that determine the prescription of antibiotics in the country. But that's another subject for another day. So we'll just go on to the numbers and the most common adverse events. And we all know that. Medication errors become the most common. That's about prescription, that's about administration, that's about all those rights and wrongs. And I'm not going into the theory part of it. All those books written on patient safety and the terminologies, I'm going to just stick to the ground realities, the way things are, and how do we really try to solve them. So medication errors, healthcare associated infections, unsafe surgical procedures, unsafe injections, even unsafe transfusions, they are all major causes of errors that cause harm to the patient. And I'm using errors as a broad category, so not going into those fancy slips and errors and all those definitions. So error means anything that you do by an act of commission or an omission which results in harm to the patient. And common type of errors, once again, are reasons for errors, I would say, not types, is medication errors, miscommunication. And miscommunication is one of the biggest underlying cause behind those errors. Incomplete documentation and charting resulting in information loss, wrong treatment of procedure, and there's some data coming from our specialty anesthesiology that with every handover there's 6% information loss. So we imagine the amount of information loss and the resulting harm to the patients. Wrong treatments of procedures, so wrong surgery, wrong site and all. Delays in patient care management plans, incomplete information, patient transitioning particularly when the patient is transitioning from one specialty to other. One of the major problems with our healthcare system is that we do not have a structured healthcare system, and the patients, we do not have the institution of general practitioner or family physician, which forms the fundamental part of all healthcare systems. So patients are going directly to the specialists, and particularly in the elderly, we find that if you look at their prescriptions, you would find the same drug written with two different trade names. So a patient receiving two ARBs, two calcium channel blockers, two beta blockers with different names by two different specialties, and the result is substandard care. Anyway, so what we'll do is, and somehow I had an intuition that Dr. Masood Sadiq is going to prime for this. So what I have done is, there's no issue of confidentiality involved here, because these are those real cases which were discussed in the public sphere. And these are some of those cases which there's a recurring pattern to these cases. And I can cite more than one cases like this. So there's a female worker who came as a patient to a public sector hospital for surgery, and this is a real case. So the way the system works is that since the hospital does not supply the medicines, and there's no system to supply the medicines that are used and disposables that are used in the ward, they ask the attendants to bring those medicines from the pharmacy from outside, and they are generally brought in, and those include a muscle relaxant as well, because that's required by the anesthesiologist, and the anesthetic drugs and the rest, and generally an antiemetic. So this is what happened, that the patient was complained of nausea for some reason. The doctor verbally ordered the nurse to give her an antiemetic, and of course the antiemetic was supposed to be there right in the so she said, मैं मंगवाऊं, उसने कहा ना पेज कल लिख के दी थी वही पड़ी होगी. So she drew it from there. Lo and behold, turned out that it was a muscle relaxant, gave that muscle relaxant to the patient. She stopped breathing, ended up a vegetative. So what happened? The outcome. Always fix the blame, hold an inquiry, punish the culprit. So that's what was happened. looked at the root cause. We are working in a very, very unsafe system. The entire system is rotten. The system is designed for these kind of flaws. It may not be a muscle relaxant. It's just that the muscle relaxant is that extreme example wherein it is highlighted, but otherwise accidental drug injections are happening each day because of the way they are being handled. Uh, the second case. Now this case became a huge public debate. So once again, a 5-year-old, past middle of the night, Eid night, the child is brought by the parents uh, who have actually come for a holiday from UK. The child had, they were like, they were had burn wounds from on the hand from a kettle, a teapot that spilled. They brought her there. The surgical resident was there, so it was Eid night. The house was skeleton staff. The person who was supposed to be on duty, the pediatric resident, had gone home, so he asked somebody who was working in another hospital to cover the night. The surgical resident came and prescribed an ointment and an NSAID and a paracetamol. The child was crying, the parents were agitated, they said, you don't know anything, call the pediatric resident. The pediatric resident came and he said, get me Pavilon. The nurse said, Dr. Saab, ये तो anesthesia के वाले इस्तेमाल करते हैं. She didn't know it was a muscle relaxant. She knew that it was an anesthesia drug. And he said, forget it. He walked to the pharmacy, got a Pavilon, drew it, gave it to the child and said, ab theek ho jayegi, and walked out. A few seconds or a minute later, the family realized that she's not breathing, calls, all hell breaks loose. They lose the patient. Of course, the patient died. And there was that one hell broke loose kind of scenario. But you know the most important thing. So that doctor managed to escape. He had come somewhere from Sindh, went back, nobody never saw him again. After 15 years, Pakistan Medical Commission, PMDC cancelled his license after 15 years of hearing. The case was shelved. Meantime, the management and all were facing their cases. Interestingly, just before that doctor left, because he was sitting with they had retained him, and he was sitting with another doctor who said, "Ye tumne kaise diya?" And he said, "I work in the ICU each day. The patients are on ventilator, and when they're agitated, I give them this injection and they calm down." So much for the issue that you highlighted, sir. Training and certification. Okay, case 3. This is another one, a classic case. Associate professor surgery, in his free time, goes and operates in a hospital in a small clinic in the periphery, comes back. At some point in time, the clinic is run by an MBBS doctor who actually recruits the patients and calls in surgeons from all over who go and operate there. And so she starts bleeding, somehow goes into hypotension, starts bleeding. They keep on trying to manage her, and at some point, and this case came to Pakistan Medical Commission, by the way, and they ask her, they referred the patient to Mayo Hospital, where she is found in shock, and while resuscitating, she goes into arrest and dies of hemorrhage. Now the worst part, when this doctor went through the entire hearing process, so they suspended his license for 3 years and debarred him from a faculty position for the rest of his life. So, of course, then he challenged, and as the way it goes, then the case comes to the council for hearing. So when he was called to the council, and he said, "What?" And he said, "मैं कोई गलत नहीं कर रहा था. I was doing it for charity. The kind of money I was getting in return was just nominal. I was doing it because if I don't go and operate there, these patients will never get access to medicine." So this was once again a recurring theme that you would find in all the lots of cases that came to us. were about substandard care for being provided and people who were not qualified going and operating because they were the only ones available or this was the only facility available. Uh, so once again the question was accreditation. Once again there is an interesting disconnect. Now